Make sure your heater's ready for the cold weather. Get a system checkup today for only $49 and get $50 in Premier Bucks to be used towards your next repair. Premier Heating and Air offers free second opinions, so call today and experience the Premier difference. Log on to DublinPremierIsHere.com or call 300-2633. Premier Heating and Air is a locally owned and operated company. Certain restrictions may apply. Specials cannot be combined with other offers. Offer ends 11/30/24.
So, nice to meet you guys. I'm Dr. Chung. So just to get started, I think kind of explaining about where I come from and how I started kind of makes sense and why I practice the way I do. We live in rural Georgia. Our population is on the little lower side than from where I came from. I actually trained at Nova Southeastern, which is in South Florida, and then went to residency at Stony Brook for general surgery. And after 5 years of that, I decided to do a fellowship in minimally invasive and bariatric surgery. So I specialize in the stomach and hiatal hernias and GERD, reflux, and all of that stuff. So after doing that, I did have a brief stint in Arkansas, mainly due to COVID, because that was a kind of a crazy time in our world in the healthcare. So after being there for 2 years, I kind of learned that there's a lot of different ways to manage GERD and reflux. So I really got into seeing what was the best way to manage it. And when I came here, I kind of had a little bit of culture shock. It was completely different than the way I managed it before. So here, I think mainly because there's not a lot of surgeons who do hiatal hernia reflux, or it's not that well known, a lot of people are on medications for life. They've been taking them again and again and again. And they would have some severe symptoms, like people that couldn't eat solid foods, or would cough or choke at night, or had like 3 pillows under their head when they slept, or slept in a chair because they were afraid they were gonna choke. And they just become a norm for them. So after hearing all of that stuff, I really started doing a lot of outreach and kind of figuring out this GERD reflux problem that we have here. And this is actually my second time doing this talk. And from the first time we did the talk, I found some really profound amount of patients that needed a lot of help. So I was inspired to do it again. So thinking about gastroesophageal reflux disease, it's kind of a complex name for something that's called heartburn, right? So why does it occur when really we have your esophagus in your stomach and you have the sphincter, the esophageal sphincter, right? That prevents acid from going back up in your chest. So when that gets disrupted, or if it doesn't work right, then you start to have heartburn. How bad your heartburn depends on how much acid you have in your stomach, how well your stomach squeezes, how much your esophagus works. It's very complex, actually. It's not just the way it looks, but it's the way it works that makes a big difference as well. Some of the symptoms that you have are going to be caused by burning sensation when you eat, that you call heartburn, backwash of food or liquids, or really feeling like you have sour taste in your mouth. Welcome. And a lot of things that people say, like they wake up in the morning, they had this sour taste in their mouth when they wake up. That's a pretty common thing you hear about. And then pain is another thing. Sometimes, a lot of times, people might think they're having a heart attack, and it really might just be heartburn. Trouble swallowing is a pretty advanced thing. Like when this goes on, it causes a lot of esophageal injury. It can cause trouble swallowing. And having a lump in your throat. When it's so bad, it can actually affect your vocal cords as well. So then people might say they have vocal cord changes as well. Or a lot of times, especially in the elderly, as you get older, you can't protect your airway that well. And you'll notice that people get aspiration pneumonia. So you talk about elderly people and pneumonia, GERD and reflux is actually one of the big things that cause pneumonias. I got these cool pictures for you guys, and I know they're kind of complex looking, but it's just kind of showing how bad a hiatal hernia can get. And the first one is pretty much your sphincter that's supposed to be right at the level of your diaphragm, which is where you breathe from. The sphincter goes above it. When that happens, it causes a lot of pressure issues, so acid just shoots up your chest. As it gets worse, you can have more and more deformity like C or D, or you can have a combination where it occurs in like a B format where the side pushes up around it. So in order to kind of tell what's causing it, there's a lot of imaging we have to do, and oftentimes we get an EGD, which is where we do a scope, okay? So why does this happen really is because, like I said, where the stomach pushes up in your chest, that's called a hiatal hernia. And when that happens, it also causes contraction issues. meaning your esophagus might not squeeze the right way. So when it doesn't squeeze the right way, acid doesn't go down, it goes up, right? And food doesn't go down, it goes up. So those are the things that can occur. And sometimes it can happen because your stomach doesn't squeeze right. When you have diabetes, or sometimes just randomly, your stomach may forget how to squeeze properly, and it gets filled up and it pushes back up in your chest. That's called gastroparesis. And the other thing is, and this is kind of becoming more prevalent, and this is another thing that I do a specialization in, which is weight loss surgery. When you're obese, the pressure from your abdomen and you just kind of breathing hard and having a lot of difficulty causes acids to shoot up in your chest as well. So weight loss can be a great way to reduce heartburn as well. Any questions, guys? Okay. I know the pictures, what's up?
Can weight loss help with the hiatal hernia?
Yes, absolutely can. And there may be times where I might not advise you to have a hiatal hernia repair, and I might recommend having a weight loss surgery together with it, because if you're going to be, a lot of times when we do a hiatal hernia repair, no matter how good we do it, what happens is the weight will eventually make it come back again. So if you're going to live for 10, 15 plus years, sometimes I may recommend weight loss surgery for you at the same time. And that's kind of a discussion we have. Now, do I always push for it? No. If you just want the hiatal hernia repair, of course you can have that, but just with the knowledge that you may have a recurrence in the next 10 years, okay? So this picture is kind of hard to see, but what you're seeing here is a big circle like that. That circle's not supposed to be there, actually. Your muscles are supposed to be very close together. So as your muscle weakens and it spreads and stuff like that, that's what happens. That's what a hiatal hernia looks like. So how is it diagnosed? I think there's a lot of studies you can do, but the most important thing is history. I think the most important thing is history, okay? So when you talk about patients and their heartburn history, you want to hear about how long they've had it, what studies they've had done, and how much pain or let's say like what food triggers you have and how much medication they're taking, right? Those are all things that you want to know about the patient. The other studies we do you have a question?
I got a question. When you said that thing called the splinter or whatever it is,
Yeah.
I was always told, like, and the reason I'm wondering is because I have it real bad, is they say like you got a valve down there and that's what makes you.
Right.
So it's a valve, like, right?
So the valve is not working right, probably because it's mispositioned. So if you have a valve, it's supposed to squeeze correctly at that valve, right? But if your valve is out of position, what happens is there's another pressure squeezing below it, and the valve can't take it, and it starts to get disrupted. So
does the ulcer make it worse if they say you have an ulcer as well or whatever?
So the ulcer is probably caused by the valve squeezing at a wrong spot. And it's kind of hard to say why you have an ulcer. It could just be that you have just really bad reflux that's been chronically irritating it, or that your stomach's rubbing together at a wrong spot.
Well, when you've been in emergency room many times and feel like somebody poured gas down the throat, lit a match, and then you're like that for even up to a couple weeks, and
Right.
at the hospital, and they thought I had a heart attack, and I said, I ain't having no heart attack, trust me, I know.
Right. You might be someone that would have to come see me sooner than later. And I think there's a lot of reasons why you would have that. Reflux would be one of them, but it may be that your stomach's not working right. And I think that's why probably I took a lot of extra research and study into doing it, because it's very difficult to diagnose. So let me kind of go through this, because I think when you look through it, you'll kind of see why I do these studies, and it'll explain a lot of your questions as well. Okay? So the reason why we start off, and this is a great thing why you've had an EGD done, and you definitely need an EGD probably, is the way we go at it is we look at what's causing the obstruction and the reason why food's not going down, or the pain. So we start from the mouth and we go all the way down, and usually what we'll see is damage to your esophagus from reflux. And that can cause swelling and narrowing and cause food to get stuck and feel like you're choking all the time. Okay? The number one cause of esophageal cancer is now reflux. That has actually changed a lot. It used to be smoking, but now because of reflux that's not being controlled properly, it is number one cause of esophageal cancer is reflux.
Because I'm doing the same things almost that he does, where I feel like I'm choking half the time. It's certain foods I eat. It's what it is. You know.
Let me see if I can answer some of the questions you have, okay? I think the most important thing is when we start with any medical issue, right, we want to try to treat it medically, right? So we don't immediately jump to doing surgery or doing EGDs and stuff like that. A lot of times we might try to avoid triggers, try to figure out what's causing your food issues, have you lose some weight and reduce your acids. So H2 blockers, which is Pepsid, and PPIs like Prilosec or Nexium and stuff like that, those are probably one of the most common things we take, and they really change the way we manage reflux. but we relied on them a little too much, I think, because the expectation is you just take it for lifelong, right? But taking any medication for life obviously has a lot of problems. And you guys have seen the warning signs of taking medication for a long time, probably on a nighttime commercials. They're not as bad as that makes it sound, but it's probably not the right thing to do to take multiple medications constantly. I think some of the things, this is my own criteria, and a lot of people mirror this. For me, when does medication work, right? So if you're having less than 2 symptoms a week, and if you take the medication and you feel better, and also you have to do it for a short duration. So like short duration for me is about 6 months. So if you do 6 months and you feel better, the medical treatment might work for you. The other thing is, after we do that therapy, if we do an EGD or before it, if the medication heals all of your ulcerations or your irritations, then the medical therapy is right for you.
Dr. Chung, will you tell them what an EGD is exactly?
Yeah,
what you
of
do,
course.
just in case they don't know?
Yeah, so an EGD is actually a scope that's fiber optic, and what it does is you go down the mouth and you can actually see all the crevices of it. And this is actually a picture of it, kind of what it looks like when you're going down, and you can actually see what all the inflammation that's in your esophagus. So these are damages in your esophagus that you can see here, and you'll be surprised, this is actually the same person. So when you first look at it, look at all this white stuff and the damage that's around it, that's what you see the first time. After being treated for 3 months, it'll look like this. The issue with this picture still is this still doesn't look normal. It looks irritated, you see it looks jagged like that. When you have reflux for a long time, you have permanent damage to your esophagus, and that's what that looks like. So when it becomes something like that, you gotta really stop the acid reflux, otherwise you may develop into cancer or have problems.
Is that thing you calling the ECG or
EGD,
whatever it's
yep.
called? Okay, EGD. Is that the same thing as having an upper GI?
Upper GI is actually an X-ray, so that's where you actually swallow and look at the X-ray pictures. So they're actually different. And I may order one if I think I need it, but that depends
Well,
on.
I've had them go down my throat a few times.
Oh.
But I thought it's called an upper GI, like an upper and lower GI when they go down.
Upper GI just means the upper part of your stomach, but it's actually a common way of referring to a radiology study as well. So I would specifically say EGD if I was doing a scope, in my terms.
Okay.
So medication works very good, but if that doesn't work, then the next step, unfortunately, it requires some kind of surgical treatment. And the reason why we do that is because GERD essentially is caused by the fact that you have a hiatal hernia or a mismatch of your valve, right? So in order to make that work, you either have to bring the stomach down or create a new valve. So the way we do that is a crazy word called fundoplication. So I know that's kind of a complex word, but it's actually where you bring the stomach around and you wrap it around to restore a valve. And that's one way to do it. Also, there's new technology that's out there where you can do a magnetic sphincter, where you do a magnet that acts like a new valve. So the magnet's like kind of detach apart and come back together. And then the other one is actually a stapler that you can go through the mouth and actually can staple on the inside called Esophax is what it's called. It's a brand name. So that also works. So what kind of surgery you need and what kind of surgery that you should get depends on how you are behaving, your age, your comorbidities, how big your hiatal hernia is, and whether or not insurance will cover it. And that's actually kind of a big factor too, right? Insurance does matter in our care, right?
I got a question.
Sure.
Just say for instance that, you know, your insurance doesn't cover that.
Mm.
And if it's a fix that, you know, you may need weight loss surgery or one of those surgeries,
Mhm.
and you've been having problems with acid reflux in the past or still currently taking medication,
Right.
will there be like some way that, or something that you, like if the doctor could say, hey, you know, this would probably prevent this patient from taking this medication, or is that possible, you know? That
Yeah. So I think in most cases, and I'm not speaking for every insurance, but a lot of times they'll cover a hiatal hernia and reflux surgery before they cover a bariatric surgery. And that's kind of the true things. When I recommend weight loss surgery for you, it's because I've looked at you as a whole person, and I've said that this is the best long-term solution for you to do. Of course, when we do the surgery, we fix the hiatal hernia at the same time when we do weight loss surgery. If I didn't do that, then you would still have acid reflux, right? So those are kind of all things that go together. that's the right thing to do. It doesn't mean that's easier for anyone to do or stuff like that, but that's the right thing to do when you fix both at the same time as your first surgery. So that's why that surgery happens. As for insurance, I think, honestly, if you're having lifelong issues and there's a lot of difficulty with it, it should be covered, especially in the cases where there's evidence of esophageal injury, you're having aspirations, reflux, chronic issues, stuff like that.
If I'm covered by the VA 100%, when you?
Yeah. Yeah. Whatever, I mean, I can't say like immediately what I'm gonna do, but at least once I got to talk to you privately, and I don't wanna spill your business in front of everyone, obviously, at that point, I'll kind of determine what's the best step to do.
So he's set up with the VA?
Yes, we are set up with the VA. We get referrals from the VA quite often.
What's the difference?
We wanna make sure that everything goes through insurance because, you know, I think the other thing is financial constraint and stuff like that. So I would say I rarely ever see someone who has to pay out of pocket. Like it's very rare, and especially VA, we get plenty of patients from the VA, so everything should be covered. And you can get that check beforehand as well. You guys have a lot of good questions, and I really appreciate that. When should you see a doctor? I think just the gist of what I'm getting from our group here, I think most of you guys probably, it wouldn't hurt to actually be seen, you know, to get a more in detail about what's going on. It might require an EG to kind of see what's going on. But a lot of times, if you kind of spend the time in talking to the patient, you'll kind of understand that people have had problems for lifelong. They're having a lot of issues with symptoms that really impede their quality of life, right? Or they might not have the normal voice that they used to have because just so much acid has been damaging it. There's a lot of things that you can kind of indicate and see, and I think a part of this talk is to kind of educate the community that you don't need to suffer with this for a long period of time and end up having, you know, life-changing diagnosis or permanent injury to your esophagus or even possibly cancer, right? Those are things that we want to prevent, okay? Yes, so for me, I think the main thing is a lot of times if medications don't work, if you've been on medication for a very long time, and especially if you have like a hiatal hernia that can't be fixed by medication, no matter how much medication you take, if you have an anatomic issue, or say like your stomach doesn't work the right way, you need some kind of way to prevent acid from damaging your esophagus. So that's when I kind of recommend surgery for you guys. And if there is a lot of weight-related issues, it may be that I may help you lose weight, whether that's surgery-wise or even just medically help you lose weight so that you're in a healthy BMI so you don't have another recurrent hiatal hernia. If you're gonna have surgery, you wanna have the one good surgery that's gonna work for you. You don't wanna be going backwards later and saying, hey, that didn't take, let's go and fix it, right? That's not the way you wanna do it. So if I do recommend it, it's probably because I'm looking out for you.
I've been on Prilosec, I know, over 10 years. Is that not good?
Well, the issue with Prilosec is over a long period of time, it actually exposes you to more higher risk of infection and can cause some blood issues as well. I'll put it that way. So it's not something you want to be on a long period of time. Also causes calcium deficiency as well because it blocks your ability to absorb calcium. So a lot of times, people who are on it for a long time will have really bad bone density. And especially for our female patients, I think that's a very big deal. So if you notice that your vitamin D or calcium is always low, it's probably because you've been on Prilosec for a long time. Yeah, so those are good reasons, I think, to try to not stay on the medication permanently. Any more questions? Well, thank you guys for the good questions today.
Hi, I'm Liz Green with Fairview Park Hospital, and while we always love to encourage the ladies in our community to get their yearly mammogram during October, the month of pink, we also realize that breast cancer does not discriminate against month, time of year, or who it affects. We are proud to offer a boutique, comfortable experience here at the Breast Center at our outpatient imaging center on Fairview's campus. We're pleased to offer a quiet, private waiting area for those who are here for their yearly mammo, along with a mammo suite that's up to date on the latest technology, 3D mammography. We're also pleased to offer walk-in appointments for those who may not have had the opportunity to schedule an appointment. And you don't need a doctor's referral for a screening mammogram. We hope you'll consider to come have your yearly mammogram with us as we strive to partner with every woman on their healthcare journey. If you're interested in learning more about our breast center or scheduling an appointment, please feel free to call us at 478-274-3919 or visit us at our website.
We have a lot to be thankful for here at Dublin Nissan, and we'd like to pass on those blessings to our customers with savings like these. 2025 Rogues starting at $31,745. We do Thanksgiving well here at Dublin Nissan.